Awesome. And then I'd like to thank Natasha for setting this all up, and then Nance and everybody else that's helped put this together. So, and sorry I'm late, but I was actually taking care of a ski injury for reals. So, all right. A little bit of background. I think most people, I've been here for about 10 years, so I think most people know my background. I grew up in Tahoe, went away to school, and then I've come back. I did a sports fellowship here in Tahoe back about 10 years ago. Was in the military, and then one of the doctors up here that were part of the U.S. ski team. And then my high school that I cover is Douglas High School down in the valley. So just a little bit of an overview. We're going to talk about a little bit of anatomy, epidemiology. I'm sure Caroline and Alan have kind of gone through some of this stuff, so I won't try to belabor it. And then mechanism of injuries and diagnosis and then treatment. And then I'm not going to really talk about prevention because I think Alan and Caroline did a great job about doing that, so I'll just skip over that stuff. So if you look at ski injuries and snowboarding injuries, really ski injuries up until the 1980s usually were the only kind of injuries you see on snow sports, downhill, and then snowboarding came into existence in the 80s. From the 40s to the 70s, there was a much higher rate of injuries, and that was just because of the way that the equipment was. It was bindings, did not release, and so you'd see a higher rate of injuries. And as newer technologies came into existence, those injury rates dropped. And we also saw a change in the different type of injury that we see. We used to see boot top injuries, fractures, things like that, and now we're seeing more ligamentous type of injuries. And if you look at it, if you ski a lot, you're an avid skier, the chances are you will get injured. For every 300 days of skiing that you do, there's a chance that you will get injured. So it's just like anything else. The more you do, that rate, that risk goes up. And this is just a little bit of technology. You can see those are the old stuff back there. I don't know if this pointer, I might be able to do that. There we go. So yeah, so obviously much older technology there. And this is the newer technology. And really the change in bindings really kind of changed the injury rates and the type of injuries that we see. Interestingly enough, 20 to 30% of ski injuries that we see are knee injuries, and the majority of them actually are not ACL injuries. It's really MCL injuries and the other ligaments. But ACLs are prevalent, and just as Caroline alluded to, there's a few reasons why. And it's usually a combination of injuries. You don't usually see an isolated injury, but you'll see a combination of injuries of ligament and meniscus and cartilage injuries. And like I said, the biggest change that we've seen is it's gone more from fractures. We still see them, but we also now see more ligamentous injury just based on the technology. Interestingly enough, females are much higher risk of getting ACL injuries than males, and there's a few reasons for that. One, Caroline already talked about, is most females are what we call quad dominant. That means that their quadriceps are stronger than the hamstrings, and the quadricep muscle is important for leg extension, and when it fires, it brings the tibia forward and stresses that ACL. And so it really is focusing on that conditioning, is looking at trying to strengthen your hamstrings, your glutes, things that can help counteract that force. And then the other thing is just the way the female anatomy is. They have a little bit wider pelvises, and so their knees become a little bit more knock-kneed, or what we call genu valgum. They come in more, and that puts stress on the ACL as well. And then when you look at their notch, and I'll show an anatomical picture, they have a little bit more narrowed notch where that ACL ligament lives, and so it has a little bit more risk of pinching it or tearing it. And then lastly is females are, it's hormonal, and so they have more estrogen. Estrogen's good at increasing the ligamentous laxity, and so it predisposes them to being injured. So there are 4 reasons why you see a much higher rate of ACL injuries in females than males. The other thing that's interesting is the non-dominant leg is more at risk, and that's just, again, conditioning type of thing. So they looked at it. There was a study that came out of Europe that looked at ACL injuries in skiers, and they found that 70% was in their non-dominant leg. So you can almost make a prediction on someone based on which leg they use to kick a soccer ball, which knee is going to be injured, and it's going to be that non-dominant one. So those are things that you can focus on in that preseason conditioning, maybe trying to prevent that. Snowboarders. I like snowboarders because they have increased the rate of ski injuries. I've yet to see a skier come in and say, or a snowboarder come in and say, I've been taken out by a skier, but I always see a skier come in that says I was taken out by a snowboarder. So to me, snowboarders have actually helped ski injuries. Snowboarders do get knee injuries, but they most commonly get upper extremity injuries, and that's just the way that they are going down the mountain. They are strapped into that board. When they fall, they are falling forward or falling backwards, and they're putting their arms out to prevent their fall. You see a lot more higher energy type of injuries on snowboarders just because a lot of the times when they get going fast, it's not easier for them to stop, and so they can get out of control a little bit faster or a little bit easier. And again, knee injuries are actually less common, but you do still see them. You see more ankle injuries and tibia fractures than you do in skiers. And again, most of the injuries are really upper extremity, wrist, elbow type of injuries.
What's the UE and LE?
Upper extremity and lower extremity. We don't know how to spell in orthopedic surgery, so we have to abbreviate everything. So, and then, like I said, the ski equipment is an important thing. So, we still have time to precondition and take your ski equipment in because we don't have a lot of snow. But at this, really at the beginning of the season, these are things you want to kind of think about: conditioning, checking over your ski equipment. You don't want to look at it in January trying to figure out your ski equipment. But the majority of injuries occur when the binding's released too late. And there's a reason why that is. It's because the majority of skiers have their binding set too high. And that's because people tend to lie about a few things. One thing they lie about is their ski level. Everybody's a level 3, and we'll go through what the different levels are, but most people are level 3s, and people lie about their weight, and, so you can, infer from there. Beginners obviously are going to be higher risk of getting injured than more avid skiers. And then the other reason why you see these knee injuries is that these ski boots nowadays, they have that forward flex, they have that built-in lean. And so when that built-in lean, they looked at biomechanical studies and it shows that you put that ACL on a little bit of stretch. And so it already starts that, that process. So, and then the shaped skis as well have a greater turning radius, but the shorter length. So it allows us more of a carve and it puts a lot more stress. So you can do faster, quicker turns, but that also increases the centripetal force going across the knee, and so it puts that stress in those ligaments. And I'm not going to pretend to know much about the binding settings. I take my skis into a professional technician and then have them do it at the beginning of each year because the bindings are extremely important. From what I see in my practices, majority of people that get injured is because their bindings or equipment was not taken care of properly. And the DIN setting is an important thing. Everybody knows about the DIN setting. It's a German acronym, and it's based off the skier level, weight, height, and then the boot. And so there's a lot of things that factor in. And so if people aren't honest about when they go in to get their setting, I'm a level 3 and I weigh, like I'd say I'm a level 3 and I weigh 150 pounds. That's obviously not true, but they'll set the binding to that, and that'll make it a much more difficult release when something happens. And advanced skiers want to have a higher set binding because you're skiing steeper slopes, you're on edge more, and so you don't want that binding to release unless it really needs to release, and so that's why you want that binding set at a higher level. And it's like anything else, if you don't know what it is, just set it in the middle. So this is just just kind of a little schematic of the binding, and you can set the level of there's a toe housing, and then there's the heel, and they have a DIN setting on both the back and the front. You can set them based on the type of skiing you're doing, and they don't have to be at the same number. They can be at different numbers, and so that's just something to kind of keep in mind. And like I said, a professional technician is going to know this stuff more than me or than anyone else, to be honest with you. And these are the different mechanisms of release, or that you see how the boot gets released. And there's twisting, there's even forward motion. So, and again, it comes down to the setting on the binding. This is a skier type. So type 1 is a very conservative, very apprehensive type of skier, beginner basically. Can only ski on groomed runs with a minimal pitch, and they are not in control of their turns at different. Basically at different pitches. So it's a beginner. Type 1 is a beginner. Type 2 is what the majority of people are, and even the majority of people around here. moderate skiers that can control themselves on a groomed run, but you get them off a groomed run into a much more steep incline or powder, things like that, and they can't control their skis as well. So type 2s are what the majority of people are. And then there's the type 3. It's an aggressive skier that can control their ski in any slope, any condition. And so you have to be honest with yourself what kind of skier you are. And that, again, can help as far as with your bindings and your equipment. So there's different mechanisms of injury. I mean, these are the 3 classic ones, but there's anything you can think of is how people get injured. So, I mean, if you think of it, that's how you can get injured. But there's a classic injury, a boot-induced injury, and the phantom foot injury. And the classic injury is a very common thing. You'll be skiing, you start to lose your balance, you start to lean forward, your ski starts, your outside ski starts to catch on its inside edge, and it starts to twist your knee. And you keep going forward, the ski keep taking back. And what it's doing is putting an external rotation force and what we call a valgus moment. That means as your ski is getting pulled this way, femur, this part of the leg is going that way, this part of the leg is going out, and it's putting stress on that inside part of the knee and stressing that MCL. And then as you're going forward, it starts to stress that ACL as well. And that's the most common type that we see as far as the mechanism of injury. Then there's the boot-induced, and these are people that, you either hit a big bump or you take a jump, you land, your back of the skis hit first, causes you to go forward, and you get pushed forward, and the tibia gets pushed forward, and that pushes the ACL, strains the ACL, and that can cause a tear. And then this phantom foot thing, this is where you're basically kind of starting to lean back, your ski starts to move forward, and as you continue to start to fall backwards, your quadricep muscle contracts to try to control your ski, and that actually makes things worse. It actually will cause your tibia to move forward, and then it causes your ACL to tear. So these are the different types of injuries. So, pick out the guy that was drinking. So, there's all different ways that we, when we're, talking to someone that got an injury, what are things that we're looking at? Classically, people say, I felt a pop. Sometimes you don't. I mean, things happen so fast, people don't know what happened. But things that you see is, you'll see some swelling. If it's happened, sometime in the distant past, people say, yeah, I injured my knee, didn't really get treatment, kind of let it go. I thought I just sprained it, but now when I go do things, I feel that the knee is giving out. Sometimes I feel like it's going to catch, going to lock, things like that. And so there's different ways that people present, but typically on a classic knee injury or ski or snowboard injury where the knee is involved, they'll feel a pop, they'll have immediate pain. They try to get up to try to ski down. They realize they can't put any weight on it. They realize they can't have any control. So they end up getting taken down by the ski patrol. So that's kind of the classic way it happens. I know. Oh, yeah.
As far as feeling the pop, I'm trying to figure out the difference between the ligamentous tears and the meniscal tears. Are you going to feel a pop from the meniscal tear? Yeah,
again, a pop is a very relative term. I mean, people feel pops for whatever reason. To distinguish that from an ACL, typically if it's if you want to know, well, did I really tear my meniscus or did I tear my ACL? If you're really sitting there thinking about that, typically if you tear a ligament, especially the ACL, it's an intra-articular ligament, so it's in the joint and there's a blood supply to it. And what will happen is when you immediately tear that, it's got a good blood supply to it. People will get almost immediate swelling in that knee. Typically with a meniscus tear, it's not as much of a blood supply. It's less of a blood supply, less arterial supply, I guess, if you will. So if you get a tear, it's a slower swelling rate. So they may not see swelling right away, but typically the next day or the day after, they'll start noticing some swelling in their knee. And so that's kind of the classic. If you had to try to separate those out. But yeah, if you just told me you got a pop, you felt a pop in your knee, I wouldn't know what it is. I mean, I'd say, yeah, it could be an ACL, it could be a meniscus, it could be cartilage, it could just be you're getting old. So there's things, there's things that we look at. And so, I know, I'm sure Alan and Caroline went through some anatomy, but the biggest thing I want you to look at on this is a schematic of the leg. And if you look here, the quadriceps, look how big the quadriceps is made up of 4 muscles, hence quad. The VMO, the rectus femoris, the lateralis, and then the intermedius. And It's a big, I mean, you look at people, they don't always, when you see them, they got, big quads. I mean, people don't show off their hamstrings. It's like biceps. Nobody shows off their triceps, but they show off the biceps. And so the quad, you can see how big, how much of a muscle mass is in there. And then you look at these hamstrings on the back, they're not a lot of muscle mass. And so you can see why most people are what we call quad dominant. And so really focusing, if you're going to do your preconditioning or preseason conditioning, focusing on those hamstrings and those glutes are really important to counteract the quad forces. So this is looking at just a schematic of the knee. This is looking at if we just cut the knee right in half and we're looking right on top of the tibia. These are the meniscus. This is the lateral meniscus. Lateral means outside. And then this is the medial meniscus. That means this is inside. Couple of things. Majority of people will tear the medial meniscus if they're going to tear it, and that's because this is not a very mobile structure. It's adherent to the MCL. You can actually see here, this is the MCL ligament right there. And so there's no mobility on that meniscus. And the meniscus is like the shock absorber in the knee. It's good for rotational force, and it's good for counteracting any kind of compression force. And what its main function is to take the load off the cartilage. But you can see if you twist your knee and this thing is now mobile, it's going to tear in these areas on the outside. While this one, the lateral meniscus, is very mobile. It only has attachments here and a little bit in the front, but it has no attachment in the back. And so when you turn your knee or when you pivot on that knee, that lateral meniscus moves. And so that's one of the reasons why it's not as injured as the medial meniscus. And then when we look here, this is the femur, this is the tibia, this is a right knee. So this is the fibula out here. This is the ACL, and you can see it. So this is what I was talking about, the notch. And when you look at this in the notch, in females, their notch is much less wide, and so it can act as a pinching mechanism. So when someone hyperextends their knee, especially in a female, it can compress at that ACL insertion and cause a tear. And so you can't change your anatomy, but this is one of the reasons why. And then this is just looking at, not to get into the detail of it, but the ACL is two bundles, and it's tight in flexion, one of the bundles, and one of the bundles is tight in extension. And so sometimes you can just injure one bundle and not the other, depending on the type of mechanism of injury that you get. So this will be the moment of truth about playing a video. So one way we kind of checked and see if someone's injured, if whoever's had their knee examined or injured, this is the classic thing that we call a Lachman test. This test, in experienced knee surgeons, you can tell the sensitivity is about 90% and about 95% specific. So as doing a lot of these, you can tell almost on exam if someone has torn their ACL or not. And so this guy is actually a guy we did last week, and this is his exam. So we'll see. Keep your fingers crossed. Watch his knee. Look at that tibia. So he has no resistance on there. So I'm pulling forward on the tibia and pushing back on the femur, and that tibia is just going forward. You guys want to see it again? So watch, I'm pulling forward, and you can just kind of see that tibia just kind of moving. See, shouldn't move that much. And we grade at 1, 2, and 3. A grade 1 is less than 5 millimeters of what we call translation. Grade 2 is 5 to 10, and then a grade 3 is greater than 10 millimeters. And his is a grade 3. It's going past a centimeter of translation. And what you can't see is that there's not a hard endpoint. Some people are a little bit lax, so you'll pull on them and they'll go a little bit forward, but you'll feel a solid endpoint. And that's just somebody's anatomy. What I'm feeling for is how much they translate, but also how much of an endpoint there is. And if there's no endpoint, we call it a soft endpoint, then we know for sure that thing is out. MRIs have done wonders for diagnosing knee injuries. And so this is an MRI. This is what we call a sagittal view. That's if we cut your leg right in half this way. I'm looking at the femur, I'm looking at the tibia, and I'm looking at the knee right in half, right in the middle of the knee. And this is what a normal ACL looks like on this view right here. You can see this nice black structure right there. That's an ACL. That's what it should look like. And this is an abnormal one. Not the greatest example, but you can see it's just kind of this wavy kind of glob of tissue right there. That's a torn ACL right there. And then same thing with the meniscus. Meniscus, this is again the femur, tibia. If you can imagine when we were looking at those meniscus from the top, now instead of looking at it from the top, we cut it in half this way. It looks like what we call little bow ties or triangles. And it should be a nice black triangle like you see on this one right here. These are the nice triangle. This is the front part of that medial meniscus. This is the back part of it. And if you look here, this is a torn one. See how the meniscus on the front looks good right there? That looks normal. But look at here, you can see that line right there? That's the tear of the meniscus right there. So treatment, pretty, basic initial treatment. I mean, if you injure your knee, what are the, basic things you can do? Certainly the RICE therapy, that's rest it. You want to ice it. Compressive wrap, doesn't have to be something that too compressive, but something a little bit snug to just kind of keep the swelling down. And then elevate. And then obviously see somebody if you've got an injury. Typically, like I said, the majority of these injuries are MCL injuries. And the good news about the MCL is it's what we call an extra-articular ligament. It's not inside the knee, it's outside the knee. And so it's outside the joint capsule. And so that means that it doesn't have any what we call joint fluid around it. So when you tear it, the blood supply to that is good. It allows a clot to form. And so the majority of MCL injuries can be treated without any kind of surgery. Brace therapy, PRP injections, if you want to get into that. Did you have a question or anybody? I thought you were all right. So ACL, the difference on the ACL, the reason why we have to do surgery on the ACL is it's an intra-articular ligament. So it's inside the knee joint. The knee has a little bit of fluid called synovial fluid that helps lubricate the cartilage and allow the knee to basically function and allow that articulation to be very, almost no friction. If you look, I see my old chemistry teacher here, so I'm trying to think. So if you look, there's what we call, coefficient of friction is for ice on ice. If you think about the smoothest ice you can possibly get and get another one and move it back and forth, the coefficient of friction is still not as good as a cartilage surface on a cartilage surface. So that is how smooth the articulation is on that. So, the only problem with cartilage is it doesn't have a blood supply. So when you injure it, game over. So, but as I was getting back to with the ACL, it's intra-articular. So we have that synovial fluid. The problem with synovial fluid is it doesn't allow a clot to form. So you have to have a clot for things to start to heal. And so when you tear that ACL in the knee, it can't really form a clot at the tear site, so you can't get any kind of healing across there. No collagen can grow across. And so that's why the ACL does not heal. And that's why we typically do surgery on it. And same with the meniscus. Poor blood supply in the joint, so the healing on its own is not good. So I don't know if you can read this or not. Sometimes I wish we had these kind of signs on people, but if you can't read it, it says, in case of an accident, it says, please, I can't even read it, but it says, so yeah, 3 symbols indicated, so it just gives you the, so this is what a knee scope is, knee arthroscopy. It's basically 2 small incisions in front of the knee, about 3 to 4 millimeters, these little incisions, and we put our camera inside. It's amazing technology. It's been around for decades. And actually now we watch a video, screen when we're doing surgery, and they've actually done a study looking at orthopedic surgeons, and they correlated that some of the best orthopedic surgeons were kids that were growing up playing video games. So if your kid plays video game, they still may have a future in something. So just think about that. But we're now able to see inside the knee with arthroscopy. I mean, it's much easier to see with a camera move around than it is to fillet somebody open and try to peek around in these little holes. And so the arthroscopy is really pretty amazing technology. So this is a normal ACL. This was on somebody I did the other day. It was normal. I didn't do an ACL surgery on them. But you can see there, that's the ligament. You'll see my probe go around it. And that's the ACL that I'm pulling on right there. You can kind of see that ligament right there. It's about 8 to 9 millimeters in diameter on people. It's not a true tubular structure. It's actually almost like I can't think of the shape, but it's kind of flat in the middle and then kind of spreads out on both sides. So it's a little bit more narrow in the middle and then it spreads out on both sides. And then this is what a normal meniscus looks like. Probe going in there. This is probing the meniscus. There's some volume there. It's nice and clear and nice and people like to have their video too of their surgery. But you can see that's my probe there with that little floater out of there. But that's what the meniscus looks like. That's the cartilage there. You can see how nice and smooth that cartilage is on the femur. And then that's the tibia that I'm pointing to. But you can see, if you look there, I think, yeah, that's the meniscus there. That's the femur. And that's the tibia. And it's a nice, smooth looking, structure. This is what a torn ACL looks like from the scope. So there's obviously a little bit of blood because it tore, but you can see, compared to the other one, you can see some of these fibers that are torn off, and you can see that's an empty wall. So that should be filled with ligament, filling that whole spot, and you can see that that is totally gone. And then this is a torn meniscus, what it looks like. You can see that flap of tissue right there. So I'm pulling on that. That thing will not heal. There's no blood supply to that spot right there. That thing will stay like that until it either gets taken out or that tear gets bigger and bigger and becomes a more difficult problem. And so, that is one of the reasons why the meniscus is such an important structure to help the cartilage, but such a vulnerable structure that it will not heal. And so when you tear that, we have to take that piece out. I'll show in the next video I think I've got. So we actually go in there, and this is actually on the same person. You might be able to see it. It's almost like real surgery because you really can't see too. So this is almost exactly recreating surgery right now. But I have a little biter that's basically nibbling that piece of meniscus out so that it's not causing that patient's complaints were he was feeling a popping, catching, locking because that piece and it looks crazy because it's that small little piece of tissue, but it causes a lot of problems. And then if you look here, this is kind of it's kind of like the cooking shows where now it looks perfect, but that's it. So we nibbled out that piece. We left as much as we can behind. We left as much of the meniscus that we could behind, but we took out the part that's torn. Back in the old days, or back before they had arthroscopy equipment, if you tore the meniscus, they would actually go in there and take this whole thing out, the whole meniscus, because they thought that the meniscus was like the appendix. They thought a vestigial structure. They didn't think it provided anything, just like, well, it's vulnerable to tearing, so when someone tears it, we just take the whole thing out. Well, they found out very quickly about there's studies that show that once you take that thing out, the meniscus, the arthritic rate went up dramatically. And so we try to save as much as we can. We're still trying to figure out ways, instead of taking it out, or if we do take this out, newer technology is actually, we're developing collagen scaffolding, injecting it with stem cells, and trying to get new meniscus material to grow back. But that's still a ways away. And then this is looking at another person that had injured their ACL. Some of the fibers a little bit tight. That's another tear of the meniscus right there in the front of the meniscus right there that we're looking at. And again, that's not repairable, so we'll take out that little piece of meniscus that's torn, and then we'll also reconstruct this person's ACL. And then this is looking at, this is obviously a quick clip, but looking at making a new ACL. So we have to drill tunnels to put the new graft in. And what you're seeing here is me drilling a tunnel into the tibia to move this new graft in. And then, so now you'll see the graft coming up. This is the new ACL.
Is that tissue then, or something?
That's a suture pulling it. So I got it's like a string I'm pulling with.
Oh.
And so you'll see I'm pulling this graft up in just a second.
Are you using cadaver ligament?
No, this is an autograft, and we can talk about that too if somebody wants to get into that. But you'll see me pull this graft up, and that's where it's going to go, where the old ACL. And so now we're doing what we're really trying to recreate the anatomy. Obviously, if we can try to create the anatomy that you were given, that we were born with, that's the ideal thing. And so we're really trying to what we call recreate the anatomy. So we're putting our tunnels, we're putting where we're putting the graft, trying to recreate that anatomy. We can't make it perfect, but we can try to get as close as we can. But you can see that's what the new ACL looks like. Looks similar to the one that wasn't torn on that other video.
So what ligament are you using?
So that was a hamstring. I used a hamstring tendon on that person. Semitendinosis, if you want to get into it, and we quadruple it. And the goal, they've shown studies, the goal is to try to get a graft of at least 8 millimeters in diameter. They've shown that less than 8 millimeter diameter grafts have a higher rate of failure rate. So our goal is to get 8 millimeters. And somebody goes, why can't you just put in a 15 millimeter diameter? You don't want to make it too big either because it's got to fit in that notch. So the ideal graft is between 8 to 10 millimeters in diameter. That's what they've shown as the ideal graft. And then this is just looking at it. What we're looking on this is the finished product. We're looking at the tension on the graft. You can see it looks like it's a nice, good tension. And then we're also making sure that the graft is not impinging on the notch. So I'm straightening the knee out right there, and then I'm flexing the knee and just making sure we got a good, what we call isometric position of that graft. So those are some of the scope pictures. So I'm not going to go into prevention. I know Alan and Caroline did a great job doing that, so I won't belabor that. I think some of the things, just as highlights to kind of think about is, again, I can't stress enough about the equipment that you want to make sure in the preseason, getting your equipment ready for, for the season, looking at your boots, looking at your bindings, making sure that those things are adjusted accordingly. And then, I'm sure they talked about warming up, stretching, but when you go out skiing, making sure you do some warm-up runs, and then also make sure you're taking breaks. I mean, skiing is an exercise, and you're up at a high altitude, and so you want to make sure you're taking breaks. And then know your limitations. That's the thing that you need to know. I still won't forget one of the first cases I did here when I got here. There's a guy who basically came in, they brought him in, he was in jeans. That's always a red flag. When someone comes in for a ski injury in jeans, that's a red flag. And then they brought his skis in with them, and these were skis that looked like they were from the 1970s. They're, everybody used to ski on those long, thin skis, like 220, So they brought him in, and so I was talking to the guy, he'd broken his femur, and I said, what happened? He's all, well, I was sitting down at the California Lodge at the bar, and I was looking up a gun barrel, and I hadn't skied in 10 years, and I thought, I could do it. That is the wrong mentality. So he put on his skis, went to the top. It was icy, terrible conditions. He took one turn, he slid all the way down and hit a tree. So, other things, helmets, they do prevent head injuries. Not all head injuries, but they do prevent them. I think you need to dress appropriately for conditions, hydrate, take breaks, eat, avoid alcohol until after you're done. And then I think knowing the snow conditions, you see different injuries based on the snow conditions. That soft, mushy kind of snow, you're going to get more knee ligament injury type of injuries. The hard ice stuff, you're going to see much higher level type of trauma. And so I think you need to know the conditions, know what conditions you can ski in, and also make sure your equipment, if it's going to be icy, you need to make sure your skis are tuned. You need to make sure you get the edges done. You need to make sure that you get the appropriate type of wax, all that type of stuff. These are some other cases. This is the case we did last week. So this is a higher level injury, a skier. And this is the tibia we're looking at and the femur. And so you can see you can get some devastating injuries. And this guy actually sustained what we call a compartment syndrome. So that means the muscle starts to expand and you have to release it or it loses the blood supply to it. So that's what we did there is we actually released that pressure by opening up the fascia. And then a few days later we come back and we close that up and at the same time we fix it. And so this is what he got. He got plates and screws. So there can be some bad injuries, and so that's why you have to be careful, know your limitations. This is obviously a higher speed injury. I'm going to show this next one because I just like to point out this lady was a skier that was hit by a snowboarder. Snowboarder edge cut right across her knee right there. So this is looking at her femur, the condyle, the femur right there. This is looking at it in surgery. This is her patella tendon. This is her kneecap. And then that's her femur. The good news was she didn't injure her cartilage at all. And the guy who injured her actually was her friend, so he felt terrible. And this is what we got right there. So this is a patella tendon. This is the kneecap, and we just kind of brought that back together. So I have to show this video. People know that I went on the Thunderbird, so I'll just show the best part of the whole trip. So the guy who's I flew with, he's now the lead guy for the Thunderbirds. So he hit the afterburners about right here, and he says, all right, we're going to get to 500 miles an hour, and then when we get to 500, we're going to pull straight up. So he says, be ready. So, and we only were about 50 feet above the ground until we hit 500 miles an hour. So that's on Minden. We're at Minden Airport. And I go, what's it going to feel like? And he said, you'll see. So I'm hitting about 6 Gs right there. And then he rolls it over. And he's, all right, you ready to go do some tricks? I said, what was that? So, but we went through all the tricks, and I didn't get sick, so I was pretty happy about that.